Good evening, everyone. I thank the Vikas sir and Dr. Prabhat for giving me this opportunity. So I'll be speaking on the management of immune-related toxicities. So this is the time of onset and resolution of the occurrence of the immune-related adverse events following the ipilimumab treatment, and these are the trajectories of the different toxicities which we see as per the timeline. And these are the different toxicities with combination and without combination with CTLA4. And what we can see is that the side effect profile is more if we combine IO plus IO, and the toxicities will have an early occurrence if you are using a combination of IO plus IO. So generally, the toxicities occur within 3 months after the initiation of the immune checkpoint inhibitors. Tissue biopsy may be useful for the higher grade toxicities if there's a confusion. Generally, patient with previous or current autoimmune diseases are at higher risk of developing the immune-related adverse events, and those patients who already had developed the previous toxicity with immunotherapy are at a greater risk of developing these toxicities. Now, those patients who are receiving the immunosuppressive therapy for the for mitigation of the immune-related toxicities, in that situation, we need to give the pneumocystis prophylaxis if they are using the immunosuppressive therapy for more than 6 weeks. The outcome of the patients on immunotherapy agents are not compromised if you are giving treatment for the in terms of the immunosuppressive therapy for the toxicities. So, see, coming to the first toxicity, that is the skin toxicity, the most common toxicity to occur with the immunotherapeutic agents. So we need to rule out the other causes for the skin toxicity. So physical examination is something which is very important. We need to do the biological assessment with the blood counts and other lab parameters. And in severe cases, the treatment should be stopped and we need to start the patient on the steroids. Now, these are the immune-related skin toxicities, grade 1, grade 2, grade 3, and grade 4. Grade 1, we need to give the topical steroids. For grade 2, topical steroids and the antihistaminics. For grade 3, we need to stop the immunotherapy and start the patient on oral steroids. While those patients who happen to get the grade 4 toxicities, we need to stop the immunosuppressive therapy and discontinue it permanently, and we need to start the IV corticosteroids for these patients. Now, coming to the endocrinopathies. So the most common endocrinopathy would be hypothyroidism. So we need to, those patients who are receiving the anti-PD-1 or anti-PD-L1 therapy should be doing the thyroid function test after each cycle. And after first 3 months, they should be doing it during the alternate cycles. Now, those patients who are receiving the anti-CTLA4 in combination with the anti-PD-L1 should be doing the thyroid function test after each cycle. And after the cycle 4, they should be doing it every 4 to 6 weekly. So we need to look at the TSH level. If the TSH levels are elevated and the low T4 is there, we need to do we need to look for the symptoms. And if the patient is symptomatic, we should start the patient on thyroxine. If the TSH is low and the T4 is low, we need to look at the 9 AM cortisol level and consider treatment for hypopituitarism. If the TSH is low and the T4 is elevated, then we need to treat the patient on the lines of hyperthyroidism. If the TSH is normal and the T4 is low, we should be doing the 9 AM cortisol and looking for the or keeping a low threshold for again hypopituitarism. If the patient is having the hypophysitis in the terms of severe mass effects, that is severe headache or visual disturbances, or patients having severe hypoadrenalism, that is hypotension, patients should be started on IV methylprednisolone. If there are moderate symptoms, that is there is a headache but no visual disturbances, we should be starting these patients on oral prednisolone. If there are vague symptoms like mild fatigue, anorexia, then we should be giving again, we should continue the immunotherapy, and we should be repeating the test in the terms of the pituitary axis hormone levels. The other toxicity is the type 1 diabetes mellitus. The blood glucose should be monitored at each visit. Patients with type 2 diabetes mellitus are at risk of developing ketoacidosis. Those patients, we should be looking for the C-peptide and the antibodies against GAD and the islet cells to distinguish between the type 1 and the type 2 diabetes. The immune checkpoint inhibitors to be started once the patient has been regulated with insulin substitution. Now, coming to the next toxicity, that is the hepatotoxicity. If the patient is having the grade 1 toxicity, we should be continuing the treatment. If patient is having grade 2 toxicity, that is between 3 to 5 times elevation of the ALT or AST, we should be told the immunotherapy treatment and start the patient on oral prednisolone. If the patient is having grade 3 toxicity, that is 5 to 20 times elevation of the ALT or AST, we should stop the treatment. If the ALT or AST is less than 400 and having a normal bilirubin, INR and albumin, we should give oral prednisolone. Else, we should be starting this patient on IV prednisolone. If the patient is having the grade 4 elevation, that is more than 20 times elevation, we should stop the immunotherapy treatment and start the patient on IV methylprednisolone. Now, coming to the GI toxicities, we should grade the diarrhea, whether it's a mild, moderate, or severe. If it's a mild diarrhea, then we should be starting the patient on symptomatic management with oral fluids, loperamide. If it's a moderate diarrhea, we should again start with the symptomatic management. But if there's no relief for more than 3 days, then we should start the patient on oral prednisolone therapy. If it's a severe diarrhea, that is more than 7 liquid stools per day, then we should be stopping the immunotherapy treatment and starting the patients on IV methylprednisolone. So the most common symptoms will be diarrhea, abdominal pain, hematochezia, weight loss, fever, vomiting. We should be looking at the other abnormalities like anemia and the raised CRP levels. We should rule out other causes for the GI toxicities like the infections. And whenever required, we should do flexible endoscopy to rule out enterocolitis. As I said, these are the summary of the recommendations of the treatment. For non-severe diarrhea, antidiarrheals. For persistent grade 2 or grade 3, grade 4 diarrhea, we should be giving the corticosteroids. So these are the immune-related gastroenteritis with the anti-PD-1. The common symptoms I've enumerated before. The endoscopic findings will be normal mucosa with mild erythema. There are different patterns of the GI toxicities like acute colitis, microscopic colitis, upper GI involvement, and pseudo obstruction. With anti-CDLA4, we can additionally have pancreatitis and small bowel enteritis. Now coming to the next toxicity, that is pneumonitis toxicity. If it's a grade 1, we should stop the treatment and look for the symptomatic resolution. If it is not resolving in 2 to 3 days, we should treat as a grade 2. In case of grade 2 toxicity, we should withhold the immunotherapy treatment, start the antibiotics, and if there's no improvement within 48 hours, then we should be treating as a grade 3 or grade 4 toxicity. If it's a grade 3 or grade 4 toxicity, we should discontinue the immunotherapy treatment and start the patient on IV methylprednisolone, and we should be doing the ancillary tests like the HRCTs and if required, bronchoscopic and bowel lavage. So the radiological features for the pneumonitis would be, or lung toxicity because of the immunotherapeutic agents would be ground glass opacities, a cryptogenic organizing pneumonia-like picture, institutional pneumonia pattern, and a pattern of hypersensitivity pneumonitis. Lung biopsy is generally not indicated until unless there is a doubt whether there is infective versus immune-related. Bronchoscopy with bowel would be required if there is a confusion between whether it's immune-related or infective. So I've enumerated the treatment for the pneumonitis toxicity before. Now coming to the next toxicity, that is the rare immune toxicities. The first is the peripheral neuropathy. If it's a mild neuropathy, then we should have low threshold to stop the immune checkpoint inhibitors. However, we can continue the immune checkpoint inhibitors. If it's moderate, then we should withhold the immune checkpoint inhibitors and start the patient on the oral prednisolone. And if it is severe toxicity, in that situation, we'll be starting the patients on IV methylprednisolone. If it's a severe, coming to the next toxicity, that is the GBS or the myasthenia. If the patient is suspected to have a GBS, we should do a nerve conduction studies, lumbar puncture study, and we should be doing the antibody testing for the GBS variants. And we should institute the patient on the IV methylprednisolone. If there's no improvement, then we should be doing plasmapheresis or IVIG. If it's a myasthenia gravis, in that situation, we should be doing the antibody titers, that is the anticholinesterase antibodies or anti-MuSK antibodies, and we should be starting the patients on the IV methylprednisolone or pyridostigmine. Coming to the next toxicity, that is a central neurological toxicity. We should be looking for the aseptic meningitis, encephalitis, or the transverse myelitis. This would be the the severe central neurological toxicities. We should be doing lumbar puncture and other ancillary tests, that is the MRI brain. And in all these cases, we should be starting these patients on IV methylprednisolone to sort of counter these toxicities. At the same time, we should rule out other conditions that may be associated with this kind of situations. So the neurological toxicity generally happens between 6 to 13 weeks. We should be ruling out other causes like the progression of the underlying cancer, seizure activity, infection, or metabolic derangements. If it's a mild toxicity, we should be stopping we should be withholding the immunotherapy treatment and looking for its resolution. If it is not resolving or it's a severe toxicity, in that situation, we should be starting there should be low threshold to start the steroids. Now coming to the next rare toxicity, that's the cardiac toxicity. Cardiac toxicities are known with the immunotherapeutic agents. We should do an early consultation with the cardiologist and we should start this patient on high-dose corticosteroids. If there's no improvement with the high-dose corticosteroids, in that situation, we should be starting these patients on other immunosuppressive therapies like infliximab, MMF, or ATG. Now, other rare toxicities, arthralgia. If it's a grade 1 arthralgia, we should start these patients on paracetamol or brufen. If it's a grade 2, that is moderate pain. In that situation, we should be starting this patient on NSAIDs. But if there's no improvement with NSAIDs, then we should start this patient on oral prednisolone. If it's a grade 3 toxicity, we should start the immunotherapeutic agent and start the patient on oral prednisolone. So the rheumatologic toxicity should be addressed in mild to moderate symptoms. We should start these patients on analgesia with paracetamol or NSAIDs. If there is a severe symptom, these patients should be started on corticosteroids. If there is no improvement with corticosteroids, then we should be starting on these patients on the anti-TNF therapy. Coming to the next toxicity, which is a rare one, that's a nephritis. If it's a grade 1 toxicity, that is 1.5 times the upper limit of the normal, if the creatinine is there, we should continue the immunotherapy. However, we should be keeping a close watch on the creatinine levels. If it's a grade 2, in that situation, we should stop the immunotherapy treatment, give the hydration for 40 to 72 hours, and if required, we should do a renal biopsy and start the patient on oral corticosteroids. If it's a grade 3, that is more than 3 times the elevation of the creatinine from the baseline levels, we should stop the immunotherapeutic agents, start the patient on fluids, and start the patients on IV methylprednisolone. For grade 4, we should be giving the treatment as grade 3, and SOS if required, we should do a renal replacement therapy. So we should be doing the baseline parameters in the terms of the serum electrolytes and creatinine. We should be looking out for the other causes like the other nephrotoxic drugs, which could be leading to the rise in the creatinine levels. For a significant renal dysfunction, we should start the patient on the injectable corticosteroids. Renal biopsy may be used to clarify the difficult differential diagnosis. The most common biopsy finding would be acute tubulointerstitial nephritis with lymphocytic infiltration. Now coming to the very rare state toxicities, that's ocular toxicities. Topical corticosteroids are recommended for episcleritis and anterior uveitis, and systemic corticosteroids are required for the severe ocular inflammation. Those patients with choroidal neovascularization, we should be giving intravitreal anti-VEGF therapy. For hematological toxicities, the recommendations for the treatment of the optimal treatment is not known. However, we should be starting these patients on high-dose corticosteroids, and if need be, we should be starting other anti-immunosuppressive therapies. There's a risk of allograft rejection while using the immune checkpoint inhibitors. However, the risk of allograft rejection is less with anti-CTLA-4 therapy. So, with the increasing use of immunotherapy across multiple indications, we should know the toxicities. The signs and symptoms are different. The immune-related adverse events occur even after finishing the treatment. We should have the experience of managing these toxicities. Early recognition and prompt management are the key. We should have access to the second-line immunosuppressive therapies like infliximab, MMF, and ATG if the corticosteroids are not working. Patient presenting unwell or previously treated with immunotherapy, think immune-related toxicities. We should rule out the other possible causes. We should be doing the ancillary test to support our diagnosis, and we should have low threshold for starting the high-dose steroids and taper it off as required. Thank you.